Hope I'm audible and visible. Can you all give me a quick thumbs up and let me very quickly check if my audio video is all fine. So, welcome all of you in this interesting session of Let's Crack NEET PG with me, Dr. Chesta Aggarwal, your dermatology educator. Now, I've myself scored All India rank 261 in my NEET PG entrance examination. Now, right now, we are offering Unacademy NEET PG Notes where you get all the 19 subjects book, and there's a very important feature here that you will also get a 1 year of an academy subscription free. To take this subscription, you need a code, and that is Chesta10. So please get your Unacademy subscription by using my code. We are also expecting a price hike very, very soon. So humble request for all the others to please get your subscription by using the code Chesta10. We have a plus subscription which give you an access to Unacademy live classes, and we have an iconic subscription which give you an access to both Unacademy and Prep Ladder. I congratulate to all the toppers who have cleared their recent exam. We had a lot of series for this month, and we are definitely expecting much more in the next coming series as well. Now we have a lot of special classes which all the educators take every day. There are many, many new courses which we have launched recently, starting with a NEET PG batch, FMG batch for mid-year exam. Then we have a FMG batch for the December exam, and we have a next batch for the next year exam. We are also having the all educator division batch where around 40 plus educators will be the part. Now this is the price list. I request all of this, all of my dear students to please be a part of it. I hope it is not stuck. Can you give me a quick thumbs up again if my audio video is fine? Fine. So I will my humble request for you all to get an Unacademy subscription using the code changed. Okay? Clear all of you? Now let's start with the first question of the today's session. A lot of images we do have today also with us. So I'm just shifting this so that you can easily visualize the question and the image. What is the correct answer? 3-year-old boy presented to pediatric department. 3-year-old boy presented to pediatric department with fever. His disease has started 5 days earlier with high grade fever up to 40 degree. The next day he was examined by a family physician and acute tonsillitis was diagnosed. We can also see a pinpoint rash and a very characteristic lines are present on the elbow. Can you tell me what can be the diagnosis here? If you want, I can zoom the image. So these are some lines which you see, and this is the characteristic sandpaper rest. Very nice. This is an example of these lines are known as fascia lines, and these rash is known as sandpaper, also known as salmon rash, also known as a very characteristic salmon rash. So please remember, when a 3-year-old female presents to you with following lesions, you are suspecting it to be a case of scarlet fever. Next question. Please answer this question. Which sign you can see here? Anyone? Ospit sign, dermographism, Kobanas, or Nikolsky sign? Which sign is shown here? Ospit, dermographism, Kobanas, or Nikolsky? Very nice. You can see that the lesions have occurred over the site of trauma. So this could be a scratch, and on that scratch you can see the lesion, very characteristic of Kobeners. Kobna's phenomena is also seen in lichen planus, psoriasis, vitiligo. What is ospit sign? Pinpoint bleeding on scratching the scales of psoriasis. Dermographism is physical urticaria. And Nikolsky sign, which is the giving away of the skin or peeling of the skin in the patients of intraepidermal split. So please remember which sign is shown in the given picture. The correct answer is option number 3, that is Koebner's phenomena. And yes, you all are right. Koebner's phenomena is also known as isomorphic phenomena. It is also known as isomorphic phenomena. Try to remember this, also known as isomorphic phenomena. Now we also have other Koebner's, that is pseudokoepners, which is because of infective organism and seeding of the surrounding skin by trauma. Example verruca, molluscum, and impetigo. So try to remember at least these 6 examples, 3 for true and 3 for pseudokoepners phenomena. Moving to the next question. Please read the question, look at the image if you want. I can show you this image. So you can see that there's a nail plate and there is some keratotic lesions just underneath it. Which nail finding is characteristic of psoriasis vulgaris? Very nice. Now this is a characteristic feature of subungual hyperkeratosis. Now in nail psoriasis we can have changes which is because of defect in the nail matrix and because of the defect in the nail bed defect. Can you name some nail matrix defects? Can you name some nail matrix defects? Anyone? We have pitting of the nail. Then what else other than pitting? What do you have? You have whitish discoloration, leukonychia, and one more thing, and that is the nail plate crumbling. What are the nail bed defect which you see? It is oil drop sign, onychomycosis, onycho, then subungual hyperkeratosis and subungual hemorrhages. All these features are the sign of nail psoriasis. Pterygium is not a feature of psoriasis. Can you tell me, Shrishti, where do you see pterygium? Pterygium is a feature of lichen planus. Lichen planus have dorsal pterygium. Good. Moving to the next question. Please look at this image. Just look at this image. You can see that there's a lot of infiltration of the skin, settling of the nose, loss of the eyebrows. What is this a classical image of? What is this a classical image of? A very interesting image based question. Very interesting image based MCQ. Srishti, Samandini, very nice all of you. I request all my students that if you want these classes more in detail with lot of explanation, more of such images, please download the Unacademy Learning app. Use my code CHESTA10, CHESTA10, and get your subscription today. We are expecting a price hike from the next month. So today you have the last day where you can achieve additional discount with amazing offers. This is a very classical feature of lepromatous leprosy, and what is it called as leonine facies. You will not see in post Kala Azar dermal leishmaniasis there is no saddle nose, there is no loss of eyebrows, no settling, no loss of eyebrows. But here both of them is present. So please remember, this is very, very important. I hope this is clear to all of you. So look at this image. This is a PKDL, and just compare the previous image with that of this image. There is no settling of the nose. There is no loss of lateral eyebrows. But if you compare this with this, I think now you can easily appreciate. In lepromatous leprosy, the eyebrows are absent. You can see that the nasal bridge is also lost. So you can easily differentiate a leonine facies from PKDL. Moving to the next question. Next. Anyone? What is the best treatment for the given condition? What is the best treatment for the given condition? What is the best treatment for the given condition? And if you want, I can just show you this image. Now here you can see that there is a lot of vesicles and there's a background of redness. Can anybody tell me what is the diagnosis here? What is the diagnosis here in this patient? Anyone can tell me the answer. Samandini Shri Patna GK. Yes, this is a case of herpes zoster. This is a case of herpes zoster. And in herpes zoster, please remember, you will see a grooved vesicles and it needs antiviral drug that is well cyclovir. Can anybody tell me the dose in which you have to give well cyclovir? Dose and duration. Can you tell me the dose and duration of well cyclovir treatment for herpes lesions? Anyone? The dosage of the treatment in the patients of herpes. Anyone? What is the correct answer? Please remember the dose is 1 gram TDS for 7 days. 1 gram TDS for 7 days, that is the dose of well cyclovir. Moving to the next question. Anybody can tell me the answer here? A patient who was on anticonvulsant presented with the rashes as shown in the image. What could be the diagnosis? Very nice. Please remember 1 gram TDS. That is 1000 mg. Yes, you are right that previously we used to give TDS, but the recent textbook even mentioned that 1 gram OD can be the treatment for 7 days. Okay, so very nice. This is a very characteristic example of fixed drug eruption where you have pigmentation whenever there is healing, and it always occurs on the fixed site. So try to remember these 2 points. Try to remember these 2 points. Next, identify the image shown. Identify the image shown. Identify the image shown here. What is the diagnosis? Anyone? What is the diagnosis here? You can see that there is some swelling which is present, and this is looking like elbow. If you look at this image very carefully, if you look at this image, you can see multiple plus point. You can see multiple plus points which are present. What is the diagnosis? What is the diagnosis here? Anyone? Identify this image. This is a very classical example of a carbuncle. Very nice. Patna GK Samandhi. Now, if you remember, we have discussed in the today's session only that whenever you have inflammation of hair follicle, it is known as folliculitis. So this is the hair. The inflammation of the superficial part, the inflammation of the superficial part here, this is known as superficial folliculitis. The inflammation of the deeper part is known as deep folliculitis. Deep folliculitis plus the involvement of the surrounding skin is known as a furuncle, and multiple furuncles together form a sieve-like structure which is known as a carbuncle. This is known as a carbuncle. So deep folliculitis plus surrounding skin inflammation, multiple furuncles, carbuncle. The correct answer of this question will be option number 1. A carbuncle, you can see multiple pus points. These are the sieve-like structures. If this is not taken care of, the pus will come out from all these spaces. So the correct answer here is option number 1. Mainly seen in diabetic patient or in those who are chronic debilitating patients. Very nice of you. Next question is on your screen. Anyone can tell me the answer? You can see a very characteristic lesion which is shown here. Can you tell me what is this? Yes. This pointer which you are seeing here, let me just change the color. These are satellite lesions. Clear, Shrishti, Kiran, Patna, GK. So these are the satellite lesions. And please remember, satellite lesion is a very characteristic feature of borderline tuberculoid. Very characteristic feature of borderline tuberculoid. So you're absolutely right, Rameshwar, Kiran. The correct answer of this question is option number 1. Next question. The person with chronic alcoholism, which disease causes this? Anyone? Person with chronic alcoholism. Yes, very nice. Anyone? I think you are all familiar with this image. I have myself shown it so many times. You have the lesion on the chest, on the exposed part. What is the answer here? Anyone? Anyone? Srishti, can you tell me the answer? Anyone can tell me the answer? I can see a lot of you with the correct answer here. Good. Now, this is a case of vitamin B3 deficiency, which is pellagra. Vitamin B3 deficiency, which is pellagra. So, very nice. Tryptophan, which is a precursor of niacin, sometimes it is deficient in the diets like those who take maize and jawar as their staple diet, maize and jawar. Plus, in patients, those who have malabsorption syndrome, malabsorption syndrome, or those who take a lot of alcohol, they do not consume proper diet, so alcoholic. And in few diseases like carcinoid syndrome, where the tryptophan is used in production of serotonin, where tryptophan is used in production of serotonin. So the correct answer of this question becomes option number 4. Identify this. What is this image? Verruca vulgaris, elephantiasis, leprosy, or leishmaniasis. Anyone? Kiran, Shrishti, Sarfaraz, GK. This is a clear-cut example of elephantiasis, which occurs very frequently because of obstruction to the lymphatics. You can easily demarcate the left and the right side, where in one the lymphatics are normal, but in another, because of obstruction of the lymphatic, you develop elephantiasis. There can be a lot of causes for such condition. Next, truck driver with a history of lesions on the penis, undergoing treatment, presented with a rash. What is the diagnosis? Just look at the image. Please look at this image, all of you. Anyone can tell me the answer? GK Rameshwar. What is the correct answer here? You can see that there are macular lesions on the palmar aspect and diffuse maculopapular rash. Very nice. It's a patient of secondary syphilis. And secondary syphilis is a great imitator, can imitate any condition. Next one. Next question. Anyone can tell me the answer here for this question? 40-year-old woman with a 2-year history of convexities of the face presented with the following lesions. Very nice. It's a case of rosacea. In a middle-aged female, if you see a background of erythema, papules and pustules specifically over the convexities, and you have telangiectasias associated, this becomes a very characteristic feature of rosacea. This becomes a very characteristic feature of rosacea. And we do have a lot of predisposing factors. Very nice, Shrishti. Next question. In which of the following you see Muir-K lines? What is the Muir-K's line? If this is the nail and you see more than one transverse band, this is known as more than one leukonychic transverse band. Very nice GK, very nice Kiran. Shrishti, this is a feature of hypoalbuminemia. Can you tell me what is the name given to the nail feature which you see in the patients of cirrhosis? What is the name given to the patients, those who have cirrhosis? Anyone? In cirrhosis or liver disease, we call it as Terry's nail. In renal failure, we call it as half and half nail or Lindsay nail. And in iron deficiency anemia, what is it called as? In iron deficiency anemia, it is known as koilonychia. That is the spooning of the nail known as koilonychia. Clear, everyone? So, in which of the following disease the Muir-K line seen? The correct answer is option number 3. Next, in which disease do you most commonly see these hypopigmented macules? Where do you see these hypopigmented macules? Neurofibromatosis, tuberous sclerosis, Darius disease, or Haley disease. Amazing, all of you. Very, very nice. These are ash leaf spots, or these are like this lanceolate hypopigmented macule. Lanceolate hypopigmented macule, very, very important for tuberous sclerosis. Tuberous sclerosis is also known as bone village disease. Also known as bone village disease. Yeah. The characteristic triad, as correctly said by Shrishti, it is epiloia, which is epilepsy, loss of intelligence, and adenoma sebaceum. And this triad is known as Vogel's triad. This is known as Vogel's triad. Next, what is the histopathological feature of lichen planus? What is the histopath feature of lichen planus? Anyone? Histopath feature of lichen planus would be histopathological feature of lichen planus would be sawtoothing of epidermis, serrate bodies, Max Joseph spaces, or all of the above. All of the above. Anyone? Very nice. The correct answer is all of the above. Sawtoothing is at the level of ridges. Serrate bodies are degenerated stratum basale. Max Joseph are the empty spaces which are left behind after the seabed bodies are absorbed. So all of the above is the correct answer. All of the above is the correct answer. Next question. This is a feature of treatment of choice for lichen planus. Yes, you can consider immunosuppressive as the treatment. And we will first start with topical steroids, and then we'll go to the other immunomodulator therapies. Very nice. Now the next question is on your screen. Anyone can tell me the answer here. This is a feature of the correct answer of this question is lichen striatus or chronic eczema or lichen planus. Please remember, this is lichenification. And what is the characteristic triad of lichenification? Increase skin thickening, then increase skin markings, and what else? Increase skin color. Increase skin thickening, skin marking, and skin color. Clear, all of you? Next, what is the answer here? Vesicles such as grain of sago is characteristic of very nice linear IgA disease, Pomfolix, lymphangioma circumscriptum, or none of the above. Vesicles such as grains of boiled sago, it is characteristic of very nice. It's a feature of Pomfolix. You have transparent vesicles which are present on the margins of the fingers or on the sides of the hands, palm, and it appears like a boiled sago, sabudana, like a boiled sago or sabudana. This condition occurs due to This condition occurs due to obstructed liver, birth injury, seborrheic dermatitis, or none of the above. None of the above. This condition occurs due to anyone, obstructed liver, birth injury, seborrheic dermatitis, or none of the above. Anyone can tell me the answer. Very nice. These are the thick yellow scales, very classical of seborrheic dermatitis in infant, which is known as cradle cap. Now, please remember these scales or seborrheic dermatitis usually do not occur in a newborn because we don't have developed sebaceous gland. But sometimes, because of transplacental transfer of the maternal androgen, you can have or you can see the involvement or you can see the seborrheic dermatitis in a newborn in the form of thick yellowish scales over the scalp. So this is cradle cap, nothing but seborrheic dermatitis of an infant. Seborrheic dermatitis of an infant. Moving to the next question. Moving to the next question. What is the correct answer? What will be the correct answer? Nevus of Ito, Mongolian spot, or hypomelanosis of Ito. Which of the following is the correct answer? Which of the following is the correct answer? Nevus of Ota, Nevus of E2, or Mongolian spot. Very nice. The answer to this question is option number 1. You can see that there is bluish discoloration. Am I visible now? Yes. So this is a very classical example of nevus of Ota. Next, first line treatment of acne comedones. I think this is a repeat question. We have already discussed it. So very quickly tell me the answer. Topical steroids, topical antibiotics, benzol peroxide. What is the answer? Amazing. Topical retinoid, which is a keratolytic drug, which is a keratolytic agent. The next question, again a very interesting image. Identify the condition shown in this image, condyloma acuminata. Very nice. This is a very classical case of condyloma acuminata, which is genital wart. We have discussed this image before also. It is because of HPV 6 and 11 infection. Because of HPV 6 and 11 infection. Moving to the next question. Moving to the next question. What is the answer here? What is the answer here? How acuminata? Please remember, Shrishti, that condyloma lata are flat lesions like this, and condyloma acuminata they are cauliflower-like. You can clearly see that there is verrucous surface over them. Okay. Now this is a very classical example of clofazimine induced therapy. Very classical example of clofazimine induced reaction. You do see hyperpigmentation on the face. You can see ichthyosis or dry patches, and you can see intestinal obstruction. Very nice. Next, a man with a non-tender indurated ulcer on the genitals with no inguinal lymph node. What can be the diagnosis? What can be the diagnosis here? Dental Q, Shrishti, Samandhi, GK. Very nice. Non-tender indurated ulcer. Non-tender indurated ulcer. Very classical of syphilis, which is because of treponema pallidum. Because of treponema pallidum. Next, patient comes with the itching in the groin since 2 months. All can be the cause except. All can be the cause except. This is a case of Tinea cruris plus corporis, which is a dermatophyte. And we all know that dermatophyte species are Trichophyton, Microsporum, and Epidermophyton. But Aspergillus species is not a, it is not a dermatophyte. Next question. Patch test is done to document. Patch test is done to document. What is the correct answer here? Anyone can tell me the answer? Anyone? What is the correct answer here? So this is a very classical image of a patch test, and please remember patch test is a type 4 hypersensitivity reaction. It is a delayed type of hypersensitivity reaction. It is the investigation of choice for contact dermatitis, and we tend to apply the allergen on the back of the patient. We will ask the patient to return after 48 hours, we'll remove it, and after 96 hours, we will read it. So, that is a very, very important feature. The next question is here, all of you. Anyone? Anyone can tell me the answer here? I'm waiting for the responses. Very nice. Now here, if you can see that there are a lot of pustules. I hope you all can see. I hope this image is visible to all of you. Yes, good. So this is a very classical feature of acute generalized pustular psoriasis, and we have discussed this that whenever you treat a patient of psoriasis, nothing happens. But on withdrawing the steroids, you tend to get a lot of pustules, and these pustules combine together to form a large areas of they combine together to form a large areas of or large lake of pus known as acute generalized pustular psoriasis. Next question. I hope this image is clear. What is the answer to this question? Anybody can tell me the answer? Very nice. Shishti GK, very, very nice. This is again a case of photodermatitis. And for photodermatitis, which is another form of contact dermatitis, you need to do a patch test. So, very well done, Dental Q, Shrishti, Samindi, GK. You will do a patch test here also to test or to check for this patient's skin lesion. And we will do a specific type of patch test which is known as photo patch test. It's a very specific type of patch test which is known as photo patch test. Here, 3-year-old child has itchy eczematous dermatitis on the flexure. His mother has a history of bronchial asthma. What is the diagnosis? Bagu, Dental Q, GK, Shrishti. Anyone? 3-year-old child has itchy eczematous dermatitis on the flexural surface. Very nice. Presence of itching, presence of eczematous dermatitis and bronchial asthma. All of them points towards the atopic dermatitis. Now, one question: what is the treatment of choice in atopic dermatitis during the active phase? So first during the active phase and second is treatment of choice during the maintenance phase. During the maintenance phase. So please tell me the answer here. Anyone? Shrishti, Bagu, Manoj, Dental Q. The treatment of choice in the active phase and the treatment of choice in the maintenance phase. What is the answer? Both with respect to atopic dermatitis, I'm asking. Very nice, everyone. The active phase, the treatment of choice is topical steroids. Okay, nowhere we are discussing about oral steroid. We are only talking about topical steroids. And for maintenance phase, we have to give topical tacrolimus. And what is tacrolimus? It is the calcined urine inhibitor. We do not give steroid for a longer duration because it has its own side effect. So we are not giving it for a very long duration. Please give me a thumbs up if you understood this point. Moving to the next one. Oral thrush is also known as. Very nice. Acute pseudomembranous candidiasis, chronic erythematous, or acute erythematous candidiasis. So this question we have discussed today also. So the answer is option number one. Next question. What is the answer here? 4-year-old girl presented with the following lesions. What is the diagnosis? What will be the diagnosis? What will be the diagnosis? Very nice, all of you. The answer to this question will be all of the above. This is a very classical case of phrynoderma, also known as a Todd skin. Phrynoderma, also known as a Todd skin. Vitamin A, vitamin E, essential fatty acid deficiency, all of them causes a Todd skin. Identify this structure. Skin biopsy punch, molluscum curate, comedone extractor, or nail elevator. What is the answer here? This is a very characteristic molluscum curate. Now, if you remember, I've shown the image of comedone extractor a few days back, which is like a spoon with a hole in the center. But if you compare that with this, you can see that it is a loop-like structure which is having pointed margin. Loop-like structure which is having the pointed margins. So you are just keeping that loop around the molluscum lesions and you are giving a tangential pull. So the molluscum lesions will come out. What is this an instrument and what is it used for? Amazing. Anyone can tell me the answer here? Anyone can tell me the answer here? 265 nanometer, 365 nanometer, 465 nanometer, or 565 nanometers. Amazing. Very nice. The answer to this question is 365 nanometer, and this is a Wood's lamp. This is a Wood's lamp. Next, tell me what is the diagnosis. Just an image. I will zoom it for you. First, have a look. Try to identify all the layers. This whole thickness is stratum corneum. Stratum granulosum is not visible. You can see stratum spinosum, and you can see that the dermal papilla are reaching very much at the top, causing suprapapillary thinning. So, what is the diagnosis? I've given you a lot of hint. A lot of hint has been given. Please try to solve this. Very nice. Please tell me the answer. Very nice. What lichen planus, psoriasis, plantar keratoderma? The answer is psoriasis. We see hyperkeratosis plus parakeratosis. We see agranulosis, suprapapillary thinning, and we see dilated blood vessels, tortuous, dilated tortuous blood vessels in dermal. Very nice. Shrishti, Dental Q, Samindhi, Tony. Next question. Tell me what is this instrument? Tell me what is this instrument? What is this instrument? What is the correct answer here? Liquid nitrogen, liquid carbon dioxide, liquid oxygen, and liquid carbon monoxide. What is the answer here in this? The correct answer of this question is it's a cryogun, which is used for cryotherapy. It's a cryogun which is used for cryotherapy. It's a cryogun which is used for cryotherapy. Let's move to the next question. Let's move to the next question. A child scratches his hand with a pen and a red wheel appears, which persists for 30 minutes. What would be your diagnosis? What can be your diagnosis? Anyone? Anyone? Okay, so if you want to follow the dermatology classes, I would highly recommend Shreyas. Please do take an academy subscription now using the code CHESTA10, where I have recently finished a comprehensive course of dermatology, a comprehensive course on dermatology. So you can use my code CHESTA10 and you can finish up with this comprehensive course on dermatology. This you can, I think, take a 3 month subscription. That would be enough for you, Shreyas. The answer here is dermographic urticaria. Recurrent oral ulcers with pain, erythematous halo around them. What can be the diagnosis? Anyone? The answer here would be Effer's ulcer. The ulcer with the white base and erythematous halo or erythematous surrounding. Very characteristic description. Very characteristic description. Next, next question. Very nice. The answer to this question is Treponema pallidum. The answer to this question is Treponema pallidum, and it is an example of secondary syphilis. Next question. This is a very easy question, and those who are attending my classes, you must be knowing this. 5-year-old male had multiple hyperpigmented macule over the trunk. On rubbing the lesion with a rounded pen, he developed an urticarial veins confined to the borders of the lesion. What is the most likely diagnosis here? What is the most likely diagnosis here? Anyone can tell me the answer? Very nice. Okay. Now for this question, it is clearly mentioned that patient has hyperpigmented macules over the trunk, and on rubbing them, the patient develops urticarial vein. Very classical of Barrier's sign, which is seen in the patients with cutaneous mastocytosis. And the most common cutaneous mastocytosis in children is urticaria pigmentosa. Urticaria pigmentosa. Next, next question. What is the answer here? What is the answer here? A patient with fever, severe joint pain comes to you. She also develops pigmentation of the nose. What is the likely diagnosis? Please remember the correct answer here is a chick sign. The correct answer here is a chick sign. Okay, clear all of you? So, what is a chick sign? It is a centrofacial pigmentation which is very characteristically seen in the patients of chikungunya fever. Patients of chikungunya fever. Next one. What is the correct answer? An alcoholic patient with lesions as shown, he also has diarrhea. Deficiency of what is associated with it? Frequent repeat, the answer is tryptophan, so we don't have to worry. It's a frequent repeat question. Next, next. Very nice, all of you. It's a form of acute generalized pustular psoriasis. It's a form of acute generalized pustular psoriasis. Whenever you treat a patient of psoriasis, on giving steroids, nothing happens, but on withdrawing the steroids, the problem starts. And when you withdraw the steroids, what happens? There is sudden exacerbation of the condition. There is sudden exacerbation of the condition. Very nice, amazing, all of you. Diffuse form of hyperpigmentation is a feature of The answer is all of the above. In everything, Whipple's disease, ectopic ACTH, vitamin B12 deficiency, in everything we will see the presence of diffuse hyperpigmentation. Next, which of the following is untrue regarding piebaldism? Which of the following is untrue regarding piebaldism? Which of the following is untrue regarding piebaldism? The correct answer here is I hope you all know what are the features of piebaldism. You have a very characteristic white forelock. First of all, let me discuss a little bit about the pathogenesis of piebaldism. Now, we all know that melanocytes, they are immigrant cells. They are not present in the skin. They have not developed in the skin. They have migrated from the neural crest. So this is the neural crest, and the precursors have migrated. That is the melanoblast. During the embryogenesis, they have migrated and they have reached up to the skin. That is the stratum basic. Inside the skin, they become mature to form the dendritic cells. Now, for this melanoblast migration, we need a factor which is known as steal factor, which actually stabilizes this precursor and help in its migration. It stabilizes the factor and help in its migration. But please remember what happens in piebaldism. There is deficiency of this steal factor. In piebaldism, there is deficiency of the steal factor. There is deficiency of the steal factor. And because of this deficiency, what happened? The melanoblast migration do not reaches to the skin and melanocytes are not formed, giving rise to a very characteristic lesion like this. It is an autosomal dominant condition, and you also see island of normal skin on the background of the depigmented area. But it never improves with age. It never improves with age. So option number 4 is the incorrect statement. Next, anyone? Investigation shows cocci in long chain. What can be the diagnosis here? Cocci in the long chain. What can be the diagnosis? Now, cocci in long chain with honey colored crust. It is very characteristic of streptococcal non-bullous impetigo. Very characteristic of streptococcal non-bullous impetigo. Now let me explain this a little bit more in detail. Impetigo is the most common bacterial infection. It is the superficial bacterial infection of the skin. It is the superficial bacterial infection of the skin. Now please remember, we have two types, non-bullous and bullous. Non-bullous can be seen secondary to streptococcus, more commonly compared to staphylococcus, while bullous is exclusively to Staphylococcus aureus. Exclusively to the Staphylococcus aureus. Clear? Next is the another name for bullous, non-bullous is impetigo contagiosa. Another name is impetigo contagiosa, while for bullous, another name is pemphigus neonatorum. Another name is pemphigus neonatorum. So we have non-bullous type and we have bullous type. The presentation in the patients of non-bullous is you will see honey colored crust. But in bullous, you will see bulla which rupture to form a very characteristic warnish crust. It ruptures to form a very characteristic warnish crust. So please remember the answer to this question here will be option number 2. Because impetigo contagiosa is streptococcal infection and streptococcus, they are the cocci in chain. They are the cocci in chain. Plus, the image is also very characteristic of honey colored crust which is present around it. Next one. What is the answer here? 28-year-old old boy, asymptomatic dome-shaped small lesions on the forehead. He has a 2-year-old daughter with similar lesions. What can be the causative agent? First of all, tell me what can be the diagnosis. I'm just showing you this image. Can you see this discrete lesions present around the mouth or around the face, eyes? These discrete umbilicated lesions which are present around the eyes, these are nothing but molluscum contagiosum. It is a pox virus, which is a DNA virus. There is a very characteristic body which is present inside, and that is known as Henderson Peterson. That is known as Henderson Peterson bodies. Known as Henderson Peterson bodies or HP bodies. These are intracytoplasmic. These are intracytoplasmic inclusion bodies. These are intracytoplasmic inclusion bodies. Clear? Next question. Now, if you look at this image, you can see some subcutaneous nodules. Which lepra reaction presents with subcutaneous nodule? It is type 2. Which presents with subcutaneous nodule? It is type 2. So let me tell you a little bit about the different type of lepra reactions. Two type. Type 1 and type 2. We have two type of lepra reactions, type 1 and type 2. Type 1 is seen mainly in the borderline pole, that is BB, BL, and while type 2 mainly occurs towards the lepromatous pole, LL and BL. Now in type 1, we see type 4 hypersensitivity reaction, that is delayed type, while in type 3 we see type 3. In type 2 we see type 3 hypersensitivity, which is the Arthur's type. What is the clinical presentation? In type 1 you will see exacerbation of the existing lesions. We see exacerbation of the existing lesions. While in type 2 we see new crops of subcutaneous nodules. We see the new crops of subcutaneous nodules. Yeah. So we have type 1, we have type 2. We also see associated neuritis or nerve damage in the patients of type 1 lepra reaction. But in type 2 lepra reaction, we see no nerve damage but associated systemic features. What do you mean by systemic features? Systemic features like there is presence of orchitis, involvement of the eyes. All these features are more common in type 2 lepra reaction. For both of them, the treatment of choice is always steroids. It is always steroids for both of them. And in addition, you have to make sure that you never stop MDT, continue MDT, and add oral steroid if at all required. But we have a very effective drug, even more effective than steroids, that is thalidomide. But why we are not considering thalidomide as a treatment of choice? Because it has a lot of side effects. Can you just count and tell me what are the side effects? Thalidomide can have peripheral numbness or peripheral neuropathy. Second, you have constipation. What next? You have peripheral neuropathy, you have constipation, you have somnolence, you have teratogenicity, that is phocomelia, and there is one more side effect of peripheral edema. In this question, we can see that we have subcutaneous nodules, so this becomes a case of erythema nodosum leprosum, that is type 2 lepra reaction. And the drug which is given here, which causes increase in the numbness, that is peripheral neuropathy. So the answer should be option number 3. Please remember the correct answer here is not option number 1. It is not option 1. It is option number 3. Okay. Next. The patient with HIV has a white plaque on uvula, pseudohyphae were seen on microscopy. What is the likely diagnosis? The answer to this question is a patient with HIV with white plaque on the uvula, pseudohyphae seen. I think it's a very characteristic example of candidiasis, a very characteristic example of candidiasis. Okay, here a very characteristic example of candidiasis, where we have pseudohyphae or pseudo budding yeast like this. Here, next. Now, with respect to this question, I want to discuss few points. Let me discuss it here only. Otherwise, we will forget. There are different types of oral candidiasis. The commonest one is acute pseudo acute pseudo membranous, which is also very popularly known as thrush. Then we have chronic pseudomembranous. We have hypertrophic type. Then we have angular candidiasis, which is known as pearlish. Then we have acute erythematous candidiasis. And we have chronic erythematous, or also known as atrophic type of candida. We can have a lot more. Remember that commonest is acute pseudomembranous, and the first four always present with white color patch or white color lesion. But acute pseudomembranous or atrophic type or chronic pseudoerythematous, they will present with a red lesion. There was once a question asked that all of the following presents with the white color oral lesion except. So the answer which you have to mark is acute erythematous or chronic erythematous, which is also known as atrophic variety. Clear? Next question. Patient comes with the following lesion on his shoulder, chest. The lesions are scarring in the center, increases on the periphery. The most appropriate treatment of this condition would be oral steroids, anti-leprosy treatment, anti-TB treatment, or oral terbinafine. The answer here is the lesion with central scarring is always cutaneous TB, that is lupus vulgaris. Cutaneous TB, that is lupus vulgaris. Now let us discuss it very very quickly. I think that is again a very important point. The DDs of annular lesions. They can be differentiated depending upon their center. They can be differentiated depending upon their center. If center shows atrophy, the diagnosis is different. If center shows clearing, the diagnosis is different. And if it shows crusting, then the diagnosis is different. When it shows atrophy, the diagnosis is lupus vulgaris, which is cutaneous TB. When clearing, it is dermatophyte infection, which is superficial fungus. And when central crusting, it is a parasitic infection, which is cutaneous leishmaniasis. Please remember all these three differential diagnoses of annular lesion. Please remember these differential diagnosis of annular lesion. ठीक है जी, clear हो गया? I hope this is clear to all of you. Moving to the next question. Anyone? The child with soreness in mouth and rash on the hand, feet, what is the causative agent? Again, very nice. It is Coxsackie A16 and the diseases hand, foot, and mouth disease. It is hand, foot, and mouth disease. Next question. We have done a very similar question in the morning session also. If you were live in the morning special class, diagnosis of a female with hair loss involving crown, frontal scalp with maintenance of the frontal hairline. Alopecia areata, anagen effluvium, male pattern baldness, or female pattern baldness. What is the answer? Very well done. I think you all have understood this question. Here you can see an image where female have loss of hair over the crown part, but the frontal hairline is maintained. So both of them are the examples of androgenic alopecias. And in androgenic alopecias, we have two patterns. One is male pattern and another is female pattern. So this is a male pattern. So can you see what is happening in male pattern? This is the frontal margin and these are the temporal bitemporal margins. If you see that the frontal margin is receding as well as bitemporal recession is occurring. So bitemporal and frontal recession. The frontal hairline is receding backwards in male pattern. What happens in a female pattern? So this is the female scalp. The frontal line is maintained, but you will see that there is widening of the part. You have thinning of the hair on the crown. Thinning of hair on crown. Thinning of hair on the crown with maintenance of frontal hairline. With maintenance of frontal hair. Is this clear? Thinning of the crown with maintenance of the frontal hairline. So that is the different types. And here again, you can just imagine this. Let me elaborate this. This is the scalp. Frontal hairline is maintained, but you have thinning over this part. Frontal hairline maintained, thinning over this part. Very, very characteristic of female pattern hair loss. For more detailed discussion, I request all of you to please download the Unacademy Learning app. Use this code and get Unacademy subscription. This code will give you 10% additional discount. We can expect a price hike in the month of March. So those who are interested in buying the subscription, please take it today or very soon. Don't forget this code. Next question. Next. I hope it is visible to all of you. Is it clear? 30-year-old male Has a large foul smelling spreading exuberant ulcer with bright red granulation tissue over the glands. No lymphadenopathy. What is the most likely causative organism? Treponema pallidum, Haemophilus ducreyi, herpes simplex, or Calymatobacteria granulomatis. Calymatobacteria granulomatis. The answer here would be very nice. The answer to this question will be option number 4. How to solve these questions? Again, a very important part. Now we need a blank paper. I would highly recommend all of you to please make a chart which I am about to make. Whenever a question of genital ulcer comes, try to follow the points which I am telling you now. First of all, look for the lymph node status. Lymph node, no lymphadenopathy or lymph node not enlarged, and lymph lymphadenopathy lymphadenopathy present. So one is lymph node enlarged and in another lymph node is not enlarged. Lymphadenopathy and no lymphadenopathy. If it is no lymphadenopathy with a exuberant beefy red ulcer with granulation tissue which bleeds on touch. What can be the diagnosis which bleeds on touch? The diagnosis would be donovanosis, and the causative agent of donovanosis is Calymatobacteria granulomatis. Calymatobacteria granulomatis is the causative agent for this condition. Moving to the next part, lymph node present, and the description of the ulcer is painless lymph node, painful lymph node. In painless lymph node, if we have painless ulcer, which is hard in consistency, this becomes a very characteristic example of syphilis. And what is syphilis? It is an infection of Treponema pallidum. Treponema pallidum. Next, painful ulcer, painful lymph node with painful ulcer. Think about the diagnosis of chancroid, and chancroid is because of Haemophilus ducreyi. Painful lymph node with no ulcer or transient ulcer, no ulcer or very short limited ulcer. The treatment which you give here is anyone can tell me the answer or what is the diagnosis? It is LGB, which is because of chlamydia trachomatis. So if you remember this chart, you can solve any question which comes from genital ulcer. Try to remember these chart. Here, if you look at the image, no lymphadenopathy. So we are actually moving on the left hand side. No lymphadenopathy. Now the next is we have to look for the ulcer. Foul smelling, exuberant, bright red granulation tissue. So the correct answer would be option number 4. I hope everybody have understood. This is a very easy but interesting question. Only 20 minutes more. Amazing. This is nevus of ota. We have already discussed the image, a very similar image if you remember. We have already discussed a very similar image. So this is an image of nevus of ota. This is an image of nevus of ota. Next question. 25-year-old female presented to OPD with skin changes on face seen in an image given below. What would be the most likely diagnosis of such condition? It's a little difficult question because the image is not very classical, but what can you see here? You can see that there is a lesion which is present somewhere like this, and we can see some discrete lesions which is present slightly away from the main side. So where do you see this type of features? Where do you see the following feature? Amazing all of you, amazing all of you. So the 25-year-old female presented to OPD with skin changes on the face as seen in the image given below. The most likely diagnosis of this condition would be intertrigo. This is a candidal intertrigo. Now, what happens? Sometimes the patients have a habit of continuously licking the lips, and which will create a lot of moisture over this area. This can even give rise to development of candidiasis. This can even give rise to development of candidiasis. Next, 15-year-old village dwelling female presented to a dermatology OPD with erythematous indurated plaque, pseudovesicular border. What is the most favorable diagnosis? What is the most favorable diagnosis? Post leishmaniasis plaque, lupus vulgaris, tinea corporis, or sweet syndrome. Very nice. The clue to this question is pseudovesicular border. Pseudovesicles is a very classical feature of sweet syndrome. What is sweet syndrome? So let us discuss this. So we have a group of disorders which is known as neutrophilic dermatosis. Three main types which we read. One is sweet syndrome. Another is pyoderma gangrenosum. And what else? We have Behçet's disease. We have Behçet's disease. Sweet syndrome, pyoderma gangrenosum, and we have Behçet's disease. What is sweet syndrome? We have fever plus multiple painful erythematous papules and plaque over the upper trunk. It can be seen secondary to infection, secondary to malignancy like AML, ALL, and even secondary to drugs. Pyoderma gangrenosum, how does it present? Pyoderma gangrenosum presents with rapidly progressing painful ulcer, non-responsive to antibiotics or sterile environment. There is an underlying inflammatory bowel disease where ulcerative colitis is more common compared to that of Crohn's disease. And here also you can have infection, malignancy, and drugs as the predisposing factors. In Behçet's disease, what is the feature? You have recurrent orogenital aphthous. You have recurrent orogenital aphthous. What else? Recurrent orogenital aphthous. You have involvement of the eyes in the form of uveitis, involvement of joint in the form of arthritis, skin changes like furuncle, erythema nodosum, superficial thrombophlebitis. In these patients, the skin is hypersensitive and that is shown by a pathology test. We do a pathology test which indicates that the skin is hypersensitive. We shows a skin test and this is known as the pathology test. Yeah. In the patients of sweet syndrome, because of the acute state, you sometimes see pseudovesicles. And whenever you get this term, always think about sweet syndrome. Next question. Anyone can tell me the answer here? Amazing, all of you. So, what would be the most likely diagnosis of the lesion on the forehead in the patient who is 40-year-old? This is a very classical feature of acne rosacea. This is again very confusing. But if you look at this image, this is a side which is the forehead, and you can see papules and pustules which are distributed. So, in a middle-aged individual, when you see papules and pustules over the forehead, always suspect acne rosacea. Always suspect acne rosacea. Next question is here. Anyone can tell me the answer here? A very characteristic image. If you see it very carefully, you can clearly see what is given here. So if you look at this image, you can see that there are the large bullas which are actually settled. And on the margins, you can see small sized bulla. So this is somewhat like this. A large bulla and you have multiple small vesicles which are surrounded. And I've discussed this so many times that this appearance is called as string of pearl or cluster of jewel. String of pearl or cluster of jewel appearance. String of pearl or cluster of jewel appearance. What is the diagnosis? This is a very classical feature of linear IDH disease, which is also known as chronic bullous dermatosis of childhood. This is also known as chronic bullous dermatosis of childhood. Okay, so you want me to zoom the image? Yes, I can definitely do this. The large bulla and multiple vesicles surrounding it. Large bulla, multiple vesicles surrounding it. So that is how you have a string of pearl or cluster of jewel appearance. String of pearl or cluster of jewel appearance. Next question is on your screen. 35-year-old female with painful blisters over oral mucosa genitals. She gave a history of similar lesions in the past. What is the correct answer here? Now, if you look at this image, just look at this image, what is seen? Can you see this net-like pattern? Anyone? This net-like pattern is also known as fishnet pattern or chicken wire pattern. Chicken wire pattern. This is fishnet pattern or chicken wire pattern. And where do you see this fishnet or chicken wire pattern? Where do you see this? This is very classical of the intraepidermal split. This is nothing but intercellular depositions of intercellular deposits of IgG. So answer here becomes option number 2. Few other hints are painful blisters, suprabasal cleft, involvement of oral mucosa. So these are some of the other hints which give you an idea that you are dealing with a patient of pemphigus vulgaris. Let's move to the next question. Very similar to the previous one, but let's see how can you differentiate this from the other one. Can you tell me the answer? A middle-aged lady presented to OPD with painful blisters on the skin. Direct immunofluorescence is done, and all of the following features seen. Tell me what can be the diagnosis. First of all, I want all of you to tell me what can be the diagnosis here. Again, it is pemphigus. And why I'm saying this is pemphigus vulgaris because you have fishnet or chicken wire pattern. You have fishnet or chicken wire pattern. You have fishnet or chicken wire. Okay, जी, fishnet or chicken wire pattern. And I request all of you to remember that in pemphigus you have antibodies against both IgG antibodies against both desmoglein 3 and desmoglein 1. But you never see antibodies against hemidesmosome. We do not have antibodies against hemidesmosome, and that is a very important difference. We do not have antibodies against hemidesmosome. So that becomes an incorrect statement. Next question is on your screen. So we have only last 10 minutes left. It's already 1 hour and 50 or 40 minutes. So it's a very long session of 2 hours. Very nice. Next question is on your screen. The question says that we have a 40-year-old male with following skin lesions. What can be the most probable diagnosis? Bullous pemphigoid, pemphigus vulgaris, dermatitis herpetiformis, or epidermolysis bullosa. Or epidermolysis bullosa. Amazing. GK, Shubham, Shrishti, Slima. The answer to this question is number 2. Again, oral lesions with intercellular deposits of IgG. Again, it is a case of pemphigus. Next question with the image. I would request all of you to just have a look to the image. You can see that there is some dental filling which is done, and you can see the reticular pattern of or a white lacy pattern in the buccal mucosa of this patient. What can be the answer? So, lady with history of burning sensation on eating spicy food, we have bilateral white lacy streaks present on the buccal mucosa. No history of tobacco abuse, but amalgamated third molar teeth is seen. Diagnosis. Amalgamated third molar is seen. The diagnosis. The answer to this question is lichen planus. Burning sensation, dental filling with mercury containing amalgams, white lacy pattern, very, very characteristic of lichen planus. Next question is on your screen. A 50-year-old male presented to dermatology OPD with a violet colored patch on wrist and the dorsum. Doctor noticed following characteristic lesion in the patient. Which of the following is wrong in this patient? Which of the following is wrong in this patient? So one thing which is clear is that this is a patient of lichen planus. Now let us discuss how does the lichen planus patients usually presents the cutaneous lesions, the oral lesions. Starting with the cutaneous lesion of lichen planus, we describe it as 5 P's. Papule, plain top, polygonal, purple, and pruritic. Very itchy. Mucosal lesions seen in 60 to 70% of the patient. And what is the mucosal lesion? Reticular type, which is the most common, or erosive type, which is rare, but it is pre-malignant. Rare, but pre-malignant. And the last is we have nail features. We have nail features, which is seen. The most common is thinning of the nail. The most specific is dorsal pterygium, where the proximal nail fold goes and fuses with the nail bed. Because of thinning, you can have tenting of the nail, which is known as pup tent sign. You can have longitudinal lines, and if it is not taken care, even loss of nail, anonychia, loss of nail can occur. So these are some of the changes or clinical presentations in a patient of lichen planus. Lichen planus patients will present in some form like this. Cobenous phenomena, yes, you do see cobenous phenomena. Sometimes you see the white lacy pattern on the skin. Can you see this? The lesion's white lacy pattern. This is known as Wickham stripe, and it corresponds to the hyperkeratosis. It corresponds to the hyperkeratosis which is present on histopath. So number 2 is right. Number 3 is right. But Nikolsky sign, it is a feature of intraepidermal immunobullous disorders. And other conditions like bullous impetigo, staphylococcal scarlet skin syndrome can also present with these features. Next question is on your screen. Next question is on your screen. 10 minutes more for this session, a very, very long session. So 10 minutes more. I again request all of you, if you want to learn dermatology like this, please use my code Chesta10 and get your subscription or grab your subscription today. We can expect a price hike very soon. So very nice, all of you. The answer to this question is option number 3, option number 2, that is potassium hydroxide mount, because this is tinea faciae. If you remember from my session which I have taken in the morning, I have told you that depending upon the site, we have different type of tenias. So if you draw the image, okay. So the fungal infection of the hair is tinea capitis. Face, tinea faciae, tinea barbae for the beard area and male, tinea corporis for the body, tinea manum for the hand, tinea unguum for the nail, tinea cruris for groin, and tinea pedis for the foot. Here, because it is present on the face, and you can see that she is a female because there is no hair follicle, so it has to be tinea faciae. When you do a potassium hydroxide mount, you will see presence of dermatophytic hyphae. Next question is on your screen. Newborn child with solitary white, well-defined patches, solitary white, well-defined patches on the thigh, pybaldism, albinism, nevus acromicus, or acral vitiligo. What is the answer? What is the answer? It's an easy one. The answer is nevus acromicus. Because it is present in newborn, it cannot be vitiligo. And albinism and pybaldism will not present like this. So I think it's an easy question, and we will not waste much time here for the discussions. Shubham, GK, Shrishti, Baggu, GK. Next question. Now there are many students who get confused between the segmental vitiligo and focal vitiligo. So let us make an image which will actually help you understand both of them. Now what is a focal vitiligo and what is segmental? Just assume that this is the midline. Focal vitiligo means you can see multiple focal lesions. So just assume that this is vitiliginosus part. Multiple focal lesions which can be present on both the side crossing the midlines, but they are focal, they are not widespread. Segmental vitiligo, it usually occurs in a single dermatome. There will be only one lesion which will never cross the midline. It can be any dermatome of the cervical area, thoracic, lumbar, or of the extremities, but only on one dermatome which will never cross the midline. Please give me a quick thumbs up if you understood the difference between a segmental vitiligo and a focal vitiligo. We do get a lot of questions, and I've seen students getting confused for this particular. Clear? Moving to the next question. Again, we have discussed so many questions today in dermatology, so many hours of MCQ revision we have done. I hope those who are following all my classes, they are getting a lot of benefit out of it. This is a fixed drug eruption. Nothing to explain here. We have already discussed. Very quickly, tell me the answer of the next question. Very clear, straightforward. 25-year-old girl presented with erythematous papule on the face as shown. The lesion were exacerbated on excessive sweating, emotional disturbances, sun exposure. Again, a very classical question of acne rosacea. Next question is on your screen. Patient with parakeratosis pustulosa, the histopath resembles which among the following options? Histopath will resemble which among the following options? Very nice. You need to have parakeratosis in histopath and only one condition which presents with parakeratosis on the histopath, that is actinic keratosis. Next question. Next question. After taking medicine for fever, the patient develops the following lesion: erythema multiforme, impetigo contagiosa, or Stevens-Johnson syndrome. Whenever you develop a drug reaction which only involves a very limited part with atypical target lesions, it is a case of Stevens-Johnson because body surface area involved is less than 10%. While for toxic epidermal necrolysis, the body surface area involved is more than 10%. So that is a very big difference in both of them. Next question. Next question is here. Identify this condition: target lesion, macule, pustule, or a nodule. What is the answer? Target lesion, macule, pustule, or a nodule. The answer to this question is it is a very classical target lesion of erythema multiforme. Now let me draw it for you. So we have three zones. The central zone is a dusky zone. The central is a dusky zone. We have a dusky center. We have a edematous ring, edematous middle zone, and surrounding this we have a erythematous ring. We have a erythematous ring at the periphery. We have the erythematous ring at the periphery. So that is the difference. I hope it is clear to all of you. So target lesion is the feature of erythema multiforme. With this, we are done with the today's session. I hope everybody have enjoyed this. If anyone has any confusion, please do let me know. This is very, very important. We have also covered with a lot of MCQ based discussions today, and I hope they are of much benefit for all of you. Clear? Okay. Now I request all of you to please subscribe this YouTube channel, that is Let's Crack NEET PG. We also have a Telegram group with the same name. If you like this video, please give me a thumbs up. Don't forget to press the bell icon so that you get all the notifications of my classes. And please use this code to get 10% discount on Unacademy subscription. Thank you, all of you. Good night.